All right, I think we're all set, Dr. Rice.
Right, yeah, I have 10:30 as well. So we can call meeting to order. We'll start off with Shelley's roll call.
Dr. Rice. Brian Smith.
Present.
Chester Cheese. Ed Zulis.
Present.
Josh Gaither.
Present.
Chris Ramos will be absent. Christina Long.
Present.
Matt Shaw. I see you. Orlando Alcordo. Ryan Harold.
Present.
Sandy Nygaard.
Present.
Sharon Hollingsworth. And Stevie Merrill.
Present.
1, 2, 3. I count
Present.
9. We do have. Oh, thank you. We can proceed.
All right, thanks, Shelley. So just to remind everyone, we are recording this meeting. So if Shelley wants to give any other housekeeping announcements, you can do that now, Shelley.
Yeah, please be advised that this meeting is being recorded and will be posted publicly. So anything said verbally, anything viewed on the webcam, texted, or in the chat box will be recorded. Thank you.
All right, thank you, Shelley. So the first thing on the agenda today will be the Ems Report. So we have 2 attachments. There's the attendance report and the 2022 meeting schedule. So just remember that if you do miss 2 consecutive meetings, we'll reach out to you and make sure that you still want to be a representative of that, of this committee. And there are also no vacancies right now to report. And then moving on to the Bureau report, we have some department updates.
Good morning, Dr. Rice. This is Rachel Garcia with the Bureau of EMS and Trauma System. I'll go ahead and share a few updates before we move through some of the items we have outlined to share with you today. We continue to monitor policies from some of the national organizations we rely on here in the state, including NREMT, COAMS, and ACS. We understand that there are some waivers in place that are getting ready to expire at the end of this year, and we will be sharing information through Gov Delivery on some of the upcoming changes from national organizations. We continue to also monitor workforce needs here in the state. Right now, the Arizona Surge line remains active, and they are also continuing to support the Surge Staffing Initiative, providing critical care nurses to hospitals throughout the state of Arizona. We'll be pushing out some surveys with our regional EMS Council partners here at the beginning of the year to better understand both workforce needs and training interests. And we will continue to also focus on rule updates here at the department. Right now we have an air ambulance rules packet sitting with the governor's office pending approval to move forward to GERC. We also continue to meet on a monthly basis with ground ambulance stakeholders. Our next work group meeting will be mid-December, and we look forward to receiving additional feedback from subject matter experts as we work through the ground ambulance rules. We should have a new draft of rules posted and available on our website by January, and we look forward to receiving your feedback. I'll go ahead and I'll introduce some of our new staff that are sitting here in the room today. We have Adam Rodriguez, our new EMS for Children coordinator. We have Marissa Salgado, our base hospital manager. TJ McKay, our training program manager. and Cody Curl, our EMS Workforce Initiatives Coordinator, who has joined us to work on a new grant we have received. From here, I will go ahead and pass it to Dr. Bradley to give some updates on the Naloxone Leave Behind program.
Thank you. Good morning, everyone. I just wanted to once again cover the topic of naloxone leave behind. Throughout COVID, we've definitely noticed an increase in opioid-related emergencies and overdoses, and we wanted to just keep spreading the message regarding our naloxone leave behind program. We have added a section on our website that has all the resources specific for EMS agencies who would like to go live with this program. This includes a training PowerPoint you can customize to your agency, an educational pamphlet that can be given out to the providers as well. This can also be customized for resources in your jurisdiction, and a link for the Office of Injury Prevention where agencies can go to get free naloxone to hand out to the community. So again, if you have any questions, please let us know. You can email me directly, but we want to just keep getting the messaging out regarding naloxone leave behind. We think this is an opportunity to really help serve the community. Next, I will continue just a reminder about the SHARE program. One of the items that we have been doing over the last 6 months is trying to do an update on the SHARE program. Over the summer, we started reaching out to all cardiac receiving and referral centers and requesting that they resubmit any documentation to demonstrate that they still want to maintain and meet the qualifications to be a cardiac receiving or a referral center. The rationale behind this is the fact that when this program first started, hospitals had to submit that information, but we never really circled back to ensure that hospitals still met those capabilities. So that's part of the reason for the request. We are trying to be very flexible with facilities. We understand that some of the original requirements may no longer be very accessible, such as CPR education to the community, especially with COVID. And so we are really trying to streamline this to the bare minimum of what we need for facilities to maintain the status. Next, as part of the SHARE program, we are also looking to see how we can move forward with possible automation of data. This will be a long, probably a 12-month program process to work on this, but something we are committed to. Any questions about either naloxone leave behind or SHARE? All right, thank you very much.
Hello, my name is Adam. I am the EMSC for Arizona. A bit of my quick background. I graduate next month with a bachelor's from U of A from Dr. Gaither's program, actually. My background includes fire, EMS, ground and air transport, and for the last 4 years I've been an educator at Pima Community College, so I look forward to working with everybody. On to my report. The NEDARC data entry closed on November 5th. We put some good effort into making sure that that list was as comprehensive as possible. For the rest of the year, NEDARC is going to be cleaning and verifying information. And in January, when they're ready, I'll be sending out the new 2022 EMS for Children survey, promoting its awareness to EMS agencies on that list. So please be on the lookout for that. And that's all I got unless anybody has any questions. Thank you.
Thank you, Adam. And then I think the next thing we have on here is the annual report snapshots from Vatsal.
You guys hear me okay? Yeah. All right. So I will start with the trauma registry report first, then EMS report. So in 2020, we had 47 trauma centers reporting to the trauma registry and accounted for 58,041 cases, which went down a bit from 2019 cases, which were around 58,600. Of those 58,041 cases, we had 1,442 trauma deaths, which is around 2.5%. We also did kind of some analysis from the hospital discharge database to see what actually the number of injuries in the state of Arizona. So we had around 473,000 injury cases in the state of Arizona. So of those, you can say that the 58,000 were kind of a severe injury, qualified for the trauma, and got reported to the trauma registry. So of the total injuries, 3,952 deaths happened. And in our trauma registry, we had 1,442 deaths reported. Top 6 mechanisms of injury. Again, the fall was a number one mechanism of injury. It's been a number one mechanism of injury since a long period of time. Then second, followed by the motor vehicle trauma occupant. We have around 9,891 cases of trauma, motor vehicle accidents in 2020, which decreased from 2019, again, because of the COVID. We had one of the things what we noticed is that firearm injuries were included into the top 6 mechanisms of injury in 2020, which firearm was never the case previously. It was never a top 6 injury. Some of the risk factors and protective factors, if you look at it, seatbelt use was 67% among MVT occupants, and 25% of the trauma patients were suspected or confirmed of being under the influence of drugs or alcohol. That is like 1 out of every 4 accidents. They found either drug or alcohol. That would be, that is a lot, but I think with the time, I think I will sum up the trauma reports. If you guys have any questions, I can take right now for the trauma. Right, I will move on to Arizona EMS report. So in 2020, almost more than 1 million records were submitted to AZPOs. And of those million records, after removing from all the cancer records, we have 888,000 records were analyzed in this report. Those 1 million records were submitted by 166 EMS agencies. Of those, 153 were ground providers and 13 were air providers. By taking all these numbers and putting into a per day average, it tells me that 2,433 EMS incidents reported per day. Most of them, 98% were ground incidents and 2% were air incidents, which is like 17,000 some air transport happened. One of the things around the demographic, what we found out is that 50% of the incidents of like 888,000, the 50% were among age greater than 55 years old, and 5% were among the pediatric age, 0 to 17 years. If we look at the county map, what we are seeing it is that the lighter color is lower incidence, darker color is a higher incidence, and La Paz had the highest EMS incidence rates. So the rural county had more EMS incidents compared to the Maricopa County. Some of the time intervals, median time intervals for 911 calls, there is 8 minutes response time, 11 minutes in time, and 11 minutes transport time. So that's pretty good. If I'm looking at the prevalence of primary or secondary impressions of interest, what we found is that 18% of the calls were injury related and 5% were related to substance abuse. Psychiatric disorders made around 3.3%, seizures 2.6%, and opioids made around 2.6% of the calls. I think that's it for the EMS report. Do you guys have any questions for the EMS report? Thank you.
Great. Thank you, Vatsal. As always, really nicely done. And the next thing I have on my list is our EMS portal revamp announcement from Travis.
Hello, can everyone hear me okay?
Yeah.
Okay, good morning. So the Bureau has some very exciting announcements coming up. Over the next year, the Bureau will be heavily focusing on IT improvements to the EMS portal to provide additional value to our stakeholders and internal staff. These improvements will consist of a complete modernization, a visual facelift to improve the look and feel of the portal, allow for the portal to be accessed and submit various applications from any smartphone, tablet, or web browser, developing a sense of a hub where Bureau announcements, education, trainings, CEs, and wellness resources will be located. We will also create a fully online con application to eliminate the need to submit paper applications, develop a user-friendly online rates application as well, and much more. The Bureau's vision for the EMS portal is to create a hub and a one-stop shop for all tasks, duties, applications, etc. that relate to EMS and trauma. Instead of accessing the portal only when needed, the portal will be a place where individuals will want to access often due to the value it will provide in our everyday work and personal lives. During this time, we greatly appreciate feedback and involvement from our stakeholders to ensure a successful implementation that greatly benefits all parties and provides additional value to our daily, monthly, and yearly functions. If you're interested in assisting our Bureau with this exciting project, please email me at travis.connors, CONNORS, @azdhs.gov. Thank you in advance for your support and participation as we continuously look to improve our services we provide to our stakeholders. Thank you.
Awesome. Thank you very much, Travis, for that. So now we'll move on to our discussion and action items. The first one we have is the minutes from the July meeting. So if I can get a motion to discuss the meeting minutes.
Brian, so moved.
Thank you, Brian. Is that you seconding, Matt?
Sandy will second.
Thank you. Does anyone have anything to discuss or change or edit as they have reviewed the draft minutes from last meeting? If there are not any changes to be made, I can take a motion to approve the minutes.
Brian, so moved.
Thanks, Brian.
Sandy will second.
Thank you. All in favor, say aye.
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 Aye. Aye.
Aye.
And any opposed? Great, so that motion has passed. The next item on the agenda is to discuss the drug profiles for Table 2. So this is the hazmat drug profile. So there are a couple that were missing prior. Oh, sorry, I'm on the wrong thing. On my education. Sorry, put the right agenda here.
Amber, this is Gail. Do you mind if I just give a little bit of background on this lecture while we're getting going for discussion? Okay, thank you. So just to give a little bit of background on the topic for this lecture, this committee had developed a medical decision-making capacity lecture several years ago that we have updated since then. One of the things that we have noticed are some trends based on what we've seen with COVID-19 in terms of healthcare-seeking behaviors, how that's affected people going to the hospital and emergency department, but also how they're accessing the 911 system and pre-hospital care. And so we took some of the data that Boss from her team has pulled together, looking at some refusals, some trends from COVID, and then also thought this would be a good opportunity to pull together a lecture kind of tying those topics in together. So we kind of put this as a training PowerPoint together with some stakeholders, and then wanted to put this forward to this committee to review for possible approval. So just to give a little bit of background of how this topic came to be. Thank you.
Thanks, Gail. So now that I have the correct agenda up, we can take a motion to discuss this agenda item.
So moved, Brian.
Thank you, Brian.
I'll second it. Ed.
Thank you. So we can kind of walk through the PowerPoint. Essentially, I don't know if you want to start at the top, Shelley, or. So I don't know that we necessarily have to go word for word, but we'll kind of go through some of the sort of high points and topics. So first part of the attachment here is talking about some trends in medical decision making. And then through the objectives, we'll talk a little bit about, how COVID has affected our patient population to a degree, and then how we can handle that, and then some training on refusals and medical decision making. So there's the ACEP and NMSP joint statement just for educational purposes. And then this goes into several slides about the collateral effects of COVID, people not getting their required examinations and scheduled exams and elective procedures. You can keep scrolling through, Shelley. Same here, you can keep scrolling. Talking about delayed diagnoses for some major chronic conditions due to this, and how this has led to really increased patient acuity that we've seen. And so now we have some DHS data following this, some statistics about the increase in patient acuity and the refusals. So this one's from a study down here in Tucson that we did looking at opioid-related refusals. So this is a high-risk patient population, very high mortality, 2-week and 1-year mortality in this group. And in the period of time during COVID, there was a spike not only in opioid overdoses, but in the number of opioid overdoses that refused care and refused transport to the hospital. So that's this one. And then there's some other data about increases in refusals and other high acuity types. So I think we'll have some little bit updated data that we're going to put in here. And then we have some refusals by age group as well. So looking at the 2 different years, and then month over month trends again, 2019 versus 2020, looking at just the number of refusals in general is going up. And then this goes into a little bit of information about risk and liability. So how this relates to liability. And then some case examples, some of the pitfalls. And then a little bit more about refusals. Keep going, Shelley. And then we kind of talk about the components of making an informed medical decision. So making sure that we assess for cognitive impairment, the orientation not equaling cognition, and not equaling a medical decision-making capacity, but just as part of your assessment. And then that is, again, sort of the take-home point. A little bit about intoxication, situational understanding, some questions to help guide providers in determining someone's situational understanding. Information about undue influence. and then a couple more cases here to talk through. And the importance of documentation. These are just a couple of case scenarios that are related to some a bit more difficult decisions. One of the things I think that confuses providers is medical powers of attorney, so we put a little information about that in here and who can refuse on behalf of a patient, POA versus guardianship. And then the conclusion. That's the end of it. So any questions or suggestions or discussion on this item?
Hi, it's Brian.
Hey, Brian.
Is there a reason for that last slide? Is it just an attempt to get a reinforcement after the references, or because that's up further, I think?
I think this is maybe an extra slide. I'm not sure why it's done that. It might be something that we saved and stuck at the back and forgot to remove or something.
Right. And so the other question I have is this is intended to replace the other decision-making packet, correct? Is that correct?
I actually don't know that. Gail, it's going to be extra, correct?
Great question, Brian. We were going to actually bring that up. So this could certainly replace the medical decision-making capacity lecture. That one has been a little while since we updated and initially wrote it. This does have very COVID-specific items in it, so we would, on our normal cycle, I think, be able to update that and potentially remove that if COVID disappears. But thank you, Brian. I think that would be a good idea to potentially replace the other lecture.
Okay, well then my question is that there is some information in the other one that is not in here, particularly related to cases of SI and HI, which is kind of a separate, really kind of a separate concept.
Mm-hmm.
But when you're discussing it, and particularly when you get down to the concepts of how we take people against their will and the mechanisms that are different between SI and HI patients and the patient without decision-making capacity. So, maybe it doesn't need to be in here because it is kind of a separate topic, but there is confusion about those two differences.
I mean, we could potentially create a separate educational module specific to behavioral emergencies, perhaps, and leave that as a component of behavioral health management, and like you said, as being separate, and then leave this medical part as part of the medical decision making without the behavioral component.
Yeah, I mean, I think that's appropriate. I just want to bring up that is another kind of separate part of the other presentation.
Yeah, we could add a behavioral health educational module to our list and have a work group kind of take some of that information and expand it a little, perhaps.
Sorry, Amber, was that a question for me? Unfortunately, our audio has some echo in the room.
Oh, no, I was just suggesting that we create a separate behavior module to put the SAHI related stuff in.
Are you saying create a separate educational module? Our apologies.
Yeah, so Brian's comment was the SIHI related material that's useful, but not necessary for this, but didn't want to lose that education.
Got it. So maybe what we can do for this meeting agenda today is kind of work on approving this and then figuring out how best we want to move forward with either adjusting the current curriculum or maybe creating a new one. Does that sound reasonable?
Absolutely. Any other discussion related to this specific training? I certainly could take a motion to approve this if there isn't any other discussion.
I'll make a motion that we accept this and use it to replace the other medical decision-making capacity program.
This is Ryan Harold. I second that.
Thank you. So all in favor of accepting this draft training curriculum and moving forward, say aye.
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 Are there any opposed? All right, so this motion passes. The next agenda item is going to be to discuss amend and approve the STR for capnography. So Gail, do you want to give a little bit of background on this? This was something that was approved back in September, but on hold due to the length of time it took to change the scope of practice. So is there anything else you wanted to add on that, Gail?
No, thank you. I just wanted to make sure, since this was approved almost 4 years ago, that we at least eyeballed it and make sure it was still accurate and up to date.
Mm-hmm. Thank you. So do I have a motion to discuss this item?
This is Matt. So moved.
Thank you, Matt.
Sandy will second it.
Thank you, Sandy. So if you want to kind of scroll through this one, Shelley, kind of look for information. Shelley, could you go up a couple of slides? I'm sorry. One more. Sorry, one more. This one right here. I might suggest that we reorder the primary sites, just to put the upper outer thigh first, as it's the preferred location. That's the only thing I saw there. You can keep going.
Just for my clarification, when I go in to edit this, on the primary site, you want the outer thigh listed first and then the shoulder?
Yeah.
All the pictures are then of the shoulder injection site. Do you think those would need to be modified, or do you think it's clear enough that if you list thigh first, people should go for that?
Yeah, we around.
Like, Amber, all these pictures are of the shoulder injection site. I'm just wondering if people would look at the picture and think that's my primary site, because that's what the image is.
Yeah, I think we switch them so that thigh. Yeah, I don't know how to have them so many pictures of the deltoid injection. I know it's just showing how to give an IM injection, but I don't know. Does anyone think that would confuse providers or make it less clear that it's not the preferred site?
Hey, this is Ryan Harold. I think it would be good to have a good mix of both. I think sometimes in the field, when, if you go on scene and the patient has like pants on or something, and you don't have quick and easy access to the thigh, they do the shoulder a lot. So in my opinion, it would be good to have both if possible.
Maybe just stress that the lateral thigh is the best site. And it says basically the best site for infants. So it doesn't necessarily say the best site for anybody else. So I don't know.
Mm-hmm.
At least on that one slide, it specifically goes into the lateral thigh as the best site for infants, which obviously makes sense.
Mm-hmm.
Question on the packaging of epi. Are we mostly advocating the EMTs to use the multi-dose or the ampule, or either one, whatever organization, whatever they use? Or would it be easier to just have the EMTs use the multi-dose vial?
I think it's probably more cost effective to use the ampule, because a multi-dose vial, once you access that, whatever else is left is no longer any use.
I think the ampule and the and just a regular vial are both 1 milligram and 1 ml. You have the potential to get more than one dose out of either one of them. If you think of the multi-dose vial in the 30 milligram form that we carry for some other reasons, when we're really going to be doing multiple doses, and sometimes when there's shortages of 0.1 milligram ml, and those things are getting really expensive. So I don't think anybody would be out buying those. But I think the amp and the small vial are both 1 milligram ml. So
the reason I only ask is because we need to kind of elaborate that ampule, how the drug is drawn out of there. So it's easy to do the vial, but definitely we need to elaborate a little bit more on for the EMTs anyway, and how to break them using filter needles, those kind of things.
I think filter needles were noted. Filter needles were noted.
31 talks about breaking the ampule using a filter needle.
I was thinking more teaching this, or whoever. I mean, I guess it's all dependent on the training center on how to make sure that they show them appropriate ways of breaking. A picture is not enough to just have it in there. So.
Looks like slide 32 and 33 are showing a 10 ml vial.
So in the chat, that the test question also suggests that the best site for injection is the shoulder in adults.
Let's go ahead and get attachment 5C1 finished, and then we'll move on to that.
Sounds good.
5C3, thank you.
Could we then go because if it was an adult, I'd be using adult because it's much easier to get to. So could we go ahead and switch those back, and then in parentheses at the vastus lateralis put that's preferred for infants?
I mean, I know it's easier to do the deltoid in adults, but it still doesn't have the same rate of absorption as the outer thigh. So I think that the outer thigh is still preferred, even if it's not the easiest location. And if it's available, I think I would prefer that they use that if it's available. Or we're not specifying one over the other, but I wouldn't necessarily tell people that the deltoid is preferred in adults for IM epi. So there was a suggestion for, it looks like we have information about the filter needles.
Hey, Amber?
Yeah.
I think what Ron was saying in the text, in the chat box, was that on question 23, what is the preferred injection site for an adult? The correct answer is A, shoulder.
Yeah, I know, but Shelley wanted to finish one, and then we'll move on to the item.
No, cool. Oh, okay. Yeah, fair enough.
Yeah. I mean, I think that the slides, the fact that what they're saying of the best site for infants, I think this is coming from like a general intramuscular injection PowerPoint, not necessarily one that's specific to epinephrine injection, which is slightly different than the general IM injections, just based on the medication that you're giving. I think that's probably why the slides appear this way. Versus IM injection, or epi specifically.
Well, that's easy to fix on the test though, so.
Yeah. Yeah, my recommendation for the slide set is to just clarify that IM epi, the preferred site is the upper outer thigh, and that if it's not available, you can give it in the deltoid. Were there any other?
So Amber, I just did a quick check on the pictures to see if we could find some replacement for all the ones which show the steps, the lateral thigh. I don't see on a quick search finding those. We could probably replace one or two of them. I'm not sure how strongly the group feels about replacing those. I feel like they're at least a nice kind of stepwise approach for, especially for EMTs who don't normally give medications.
Yeah.
I think at least shows them in terms of each step how to do this. Unless someone would like to pose for some pictures.
Yeah, I mean, I think that that's probably fine. I just, in the verbiage, I wouldn't emphasize that deltoid is preferred for IM injection of epi specifically. So at least in the text, I would change it. If we leave the pictures, I think it's probably fine. As you guys are scrolling through this, are there any other suggestions or comments for this? Now we can take a motion to make those small changes and then approve it.
I'll make a motion that we approve this with the changes noted and on the test.
I'll second that.
All right, all in favor, say aye.
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 Any opposed? All right. So back to the agenda. The next one that we have is the skill sheet. Thank you, Shelley. This has instructions for the vial and the ampule. which includes the how to break it and insert the filter needle.
I'm sorry, Amber, you need an amendment on which line?
No, I was just stating that those, it had been discussed earlier that they are in the skill sheet as well.
Understood.
Yeah. Since this is one item, Shelley, can we, I guess I didn't realize this was all on the same item. We can do the skill sheet and the exam then together, right? Is it both?
If you like.
Okay. I don't hear any discussion of the skill sheet. Then it could be epinephrine. So if there's no discussion here, we'll look at the exam. So I just have one question on question 16. The question asks, what is the correct epidose on an adult? I don't know, does this seem like too difficult of a question in terms of drug calculations for EMT level?
That, but they have to calculate that, right? To get 0.3 to point, whether it's 0.3 or 0.5.
Yeah.
Amber, this is Dale on the phone. If I can, my comment, I think most people think of doses in the volume that they're administering.
Right.
So stating 0.3 milliliters of a 1 milligram per 1 milliliter solution, or might be more intuitive, because now they're making a step in their head. Is the 0.3 milligrams actually 0.3 milliliters? And I think just literally giving them the volume of the formulary might be the better choice. My 2 cents.
Yeah, I mean, that was what I was thinking.
Question 3 is the same thing, but for pediatrics, and it's listed as mLs. So maybe the same for adults.
But I have a question, Brian. I have a question. It seems like in a lot of the recommendations from people dealing with with pharmacy, is that doing volumes, now in this case maybe it's because we can say this is the way it comes, but that using a volume has really gone out of, I think, most people's utilization of safety issues related to the patient with that.
This is Dale again on the phone. My apologies, but I just wanted to insert one more comment of caution. I think route probably should be routinely stated because these are routinely IM and not IV. And more a point of just trying to avoid any confusion, because if the patient already has an IV, we wouldn't want someone to intuit this could be an IV dose. May not be relevant, but just thought.
No, I think that's a good idea. I think it should go in front of epi in the question. I am epi.
Okay. Question 16.
And just to clarify, Dale, are you referring to each question?
Correct. Yeah, either the answer or was mentioned in the question that the volume and concentration and route should be all in one kind of bullet point or within the question. That was my thought.
I think we could probably just word search the test, and anytime there's epinephrine, we'll make sure that IM is in front of it. Probably the easiest way to do that.
And then again, like 23, the preferred injection site for adult administration. I don't know. I guess I'm okay if they're aware that the shoulder is okay to use if it's available, but I don't think that we should specifically state that it's the preferred injection site for IM epinephrine.
Then we can just change that to answer to B on the answer sheet.
Okay.
And just to clarify, did we come up with a final decision of milligram or ml to be consistent? I think to Matt's point, probably having both the pediatric and adult question having consistent language would be a good thing.
All right, it's Brian. Could we do then like in the adult 0.3 milligrams / 0.3 mLs of the 1 milligram ml concentration?
Which question is this again? What's the other question? Oh, there it is. No, I'm fine using.
Yeah, the pediatric one just lists the mLs. It doesn't list the 1 milligram per 1 ml as part of the answer. So
Yeah. I just put in the chat box to make sure, since we're kind of doing this hybrid virtual, that as we say things, we're kind of talking about the same visual format. So just making sure that that's what the group is wanting it to look like.
Yeah, I'm okay with that. And then we would make that the same for question 3.
Yeah, again, it's Dale. Sorry if I'm belaboring the point, but the whole reason why we stepped away from 1 to 10,000 and 1 to 1,000 terminology was due to confusion between the formulations and how we administer them. So less conscious of the EMS rig on what the pre-hospital provider will grab right away. It should be pretty clear that they're always going to go to the 1 to 1,000 or 1 to 1 version when it comes to IM dosing, and never use that IV. But I more feel that I think, just for clarity, that route, volume, and formulary concentration probably should routinely accompany in every incidence it's commented on, just to avoid confusion.
So route and volume, and not also list the dose in milligrams? Or would you be okay listing it as Gail has it in the chat with a milligram/ml?
I think that looks good. Yes.
Okay.
Thank you.
Okay. Yeah, perfect. Yeah, thank you. And then the only other question I have in here is in question 2, where it says epinephrine should be used in which of the following patient situations, and the answer is all of the above. Although technically, the IM epi administration is only authorized for anaphylaxis, not for other purposes, for the EMT administration with the prepared kit. So I don't know if this is at all out of line with the technical limitations of what they can use it for.
Great pickup, Amber. Yes, we should definitely either delete the question or delete C.
Or make another, we could just come up with something else that's anaphylaxis.
And you're talking about number 2?
Yeah.
So what's the answer on the answer sheet down there? It's not all of the above, is it?
Yeah.
Oh, it is. We can just change the answer to sheet to B then.
Well, it could be B or C. Oh yeah, I guess so. Well, it could be B or C.
Asthma with cyanosis and dyspnea would not be it for the EMT. Oh, wait a minute. There's that. Yeah, because the 190-100 after and throat swelling after a bee sting, that's really contraindicated.
I don't think we list that as a contraindication in the training.
High blood pressure or hypertension, wouldn't it be?
Not if they're dying from anaphylaxis. Yes.
Yeah, I think it's just a caution for hypertension, because certainly if there's throat swelling, I think at that point the anaphylaxis is more worrisome than the hypertension.
So maybe we should rephrase that one a little, do something different on that question. Take out the throat swelling and put in hives or something like that. And then make the correct answer B on the answer sheet.
How about changing entirely and making option A, because we want option A to be false, I'm understanding. Just say evidence of throat swelling despite adequate antihistamine dosing.
I think most of our protocols list IM epi as the first line treatment for anaphylaxis and not to be given after Benadryl. So most EMS protocols will list IM epi as the first line prior to giving Benadryl.
And EMTs won't have Benadryl.
No, yeah, no, good point. I want to avoid confusion. I'm more referring to the patient who takes Benadryl and then the EMS arrives. They're going to give epinephrine anyways, despite that. Yeah, no, I'm just scratch the idea.
I mean, you could just change question C to something else and leave it all of the above and put a third. Just put a third different description of anaphylaxis. Does anyone have strong feelings against A being true? I don't specifically.
Yeah, couldn't we just say C would be like, we're just making another true statement?
Yeah.
Like, signs of hives with lip swelling after, I don't know, eating a cookie with nuts, something like that.
Yeah, I like that one. Okay. We can make that change. So this one, to summarize, the edits would be anywhere where it says epinephrine, clarify intramuscular as the route. And then replacing the sort of the way that the doses are written to mirror what Gail has currently in the chat box. Changing the answer to question 23 to be answer B, and changing the answer C in question 2 to be patient with hives and lip swelling after eating a cookie with nuts. And I think that is.
Was that 23 or 24?
That was 20. Oh, let me double check. I had written 23, but maybe that's wrong. Sorry, that one's. Adult administration is 23.
Okay.
23 to B, and then, yeah. And that's what I have for edits for that. So there were no recommended changes in the skill sheet attachment. So if anyone wants to make a motion with the edits that I just reviewed to the last two parts of the last two attachments, you can do that.
I have a quick question.
Yeah.
I was going back to the slides and it says cause of allergic reaction. Is that a good title, or should we be talking about allergens?
I didn't look at the title. The title of the presentation, or which title?
Yeah, it says causes of. I'm just brainstorming. We used allergens a lot in when it comes to some of these items. The word allergen.
I'm sorry, can you tell me which slide you're referring to?
On the presentation,
I'm not sure.
Orlando, where are you taking us?
Shirley, do you see that PowerPoint slide for EMT STR?
What slide on the PowerPoint, please?
1, 2, 3, 4. Fourth one.
Okay.
So are you saying to say allergens that cause allergic reaction? Is that what you're?
Yeah, something like that, Brian.
Oh, okay. So we could just title that slide allergens, I guess?
I think I have to bring up a point of order though,
Okay.
because we moved and accepted this, right?
Yeah, you did.
We can't fix it in the same meeting. So I'm not sure that's enough of a deal to have to move this on.
Okay.
This is Dale. May I make a comment and then shelf it? Because I'm old enough to maybe not remember it if we reviewed it down the road. Maybe common cause of allergic reactions. And I really like to emphasize the fact that most of the time we don't know the allergic trigger. So maybe the last bullet would be for future edits. The last bullet would be most patients' inciting agent is not known, or something to that effect.
Okay. I will make a note of that. Okay, so for the action item that we're currently discussing, do I have a motion to approve with those edits?
So moved, Matt.
Second, Brian.
Thank you, Brian. All those in favor, say aye.
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 And then any opposed? Okay, we'll move those two forward. Next discussion and action item will be another STR. So do I have a motion to discuss the capnography and tidal CO2 training? Again, previously approved, but several years ago.
Amber, if you are up for it, I think we can just move to approve this one. I don't know that we need to go through it from my perspective.
I have a question. It's Brian. I have a question though. I think there's an assumption being made in here that might not be always accurate, given that we recognize that medical directors can take this out and do things that they want with it. But this really focuses a lot on the waveforms for intubated patients, kind of. It's got pictures of, a tube getting dislodged. But there's nothing about other kinds of waveforms where people might be doing side stream with nasal prongs when they have a patient who's bronchospastic and things like that in here. So I guess my question is, should we consider?
If I may, Brian, having already discussed this several years ago, we chose not to include that on purpose because using a nasal cannula to diagnose asthma is ridiculous. Nobody uses a nasal cannula to diagnose asthma clinically. You listen to somebody's lungs and you listen for wheezing. And I think including that in this would be really going to a level that's beyond what we want to focus on for this level of provider.
That's fine.
So is your motion, Josh, to accept this as written?
Yep, I move to accept as written.
Okay. Have a second?
Second, Orlando.
Thank you. All in favor, say aye.
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 Any opposed? Okay, motion passes. The next item on the agenda will be the PACES work group attachment 5E, pediatric naloxone training. Is there anyone here from PACES that wants to discuss any of this?
Hi, Amber. This is Adam with EMSC. Our work group put this together and a few months ago, and we've been having a look at it since. As Dr. Wolbers describes it, we are going after the low-hanging fruit, and I like that phraseology. We figured that a push towards Narcan advocacy in pediatric populations would do just that. It would be a great benefit with very little risk. And so we thought that this collaboration producing this PowerPoint would be useful for that mission.
As a question more in relation to the order of the evaluation, PACES is still currently editing this document. And I intuit some edits that could be done, and Adam, help me out here, or Julie, if you're on the phone too, that we could either process presently or process this afternoon in PACES and then bring it back to education. Adam, do you think we're close enough with the most recent edits to process now, or should we reverse order?
I think the best course is to wait for the PACES meeting for that. I know it might set us behind a little bit, but I don't think I'm not sure the order of which things could be done here.
Okay. Do I have a motion to table this then?
Yes, we need a motion to table this at this point, unfortunately, if there's going to be further changes from the PACES group.
Yeah.
Thank you, and my apologies for that.
I move to table this.
Second, Orlando.
Okay, great. So we will table that item for give the PACES group time to finish working on that. The next discussion item is going to be the forming a work group for maternal resuscitation and interventions from the Maternal Mortality Review Committee. I don't know much about this one. Gail, is there anything else to add to this?
Sure, a little bit of background. We got a request from the Maternal Mortality Review Committee, which is part of ADHS, that has stakeholders from throughout the state, wanting to know if there was any specific education for EMS regarding maternal mortality and kind of things and techniques that could be done. They had shared a PowerPoint that they had found that was designed for pre-hospital use, and so I'm not sure if all that was relevant, but we wanted to bring this to this committee to see if this group wanted to create a work group to create a training curriculum on that subject.
Okay. Do I have a motion to discuss this item?
I would say that's a great idea. I would favor a work group to do that.
Okay, thank you.
I was wondering if maybe we could expand it a little bit. There was a recent article looking at how EMS practitioners deliver death notifications and how untrained people feel and their comfort with it. I'm wondering if we couldn't, either maybe that needs to be a separate topic or maybe it could be rolled in with that one as well.
But this would be for maternal resuscitations, correct?
Correct.
Okay.
Yeah. But I do like that topic. We can certainly add that for future topic discussion as well.
Yeah. Okay, so Josh, was that a motion from you to form a work group?
Yes.
Okay, do I have a second?
I'm showing the motion was made by Dr. Gaither and seconded by Matt Shaw.
Oh, great. Okay. Super. All in favor of forming a work group to work on the training for this, say aye.
Aye.
Aye. Aye.
Any opposed? Okay. The last item here is just a standing item. It's just the table of training modules that we have for our website that we're currently working on. So if anything has anything that they would like added to that, they could always email myself or Shelley to discuss that in future meetings. Then moving on to the next agenda item. If anyone has any agenda items to be considered for the next meeting, you can let us know now. And then the next item is a call to the public. Okay, not hearing any. A couple of upcoming events. Number 8 is the AEN's second annual EMS Fall Forum. There's an event from NAEMS, the Pediatric Symposium in Flagstaff in February, at the end of February, and then any other meeting invitations or notices can be found on the Bureau's website as well. Our next meeting will be March 17th at 10:30. And with that, if there's nothing else, we can adjourn the meeting.
So moved.
Thank you, everybody.
Thanks all.
Thank you, everybody.
Holidays, happy holidays.